Hi, everyone. We're going to go ahead and get started in just another minute or two. So thank you so much for joining us, and we'll get started in just a minute. Okay, so we are going to go ahead and get started. Thank you so much for joining me today. My name is Stephanie Fouri, and I am the director of the Cancer Legal Resource Center. Just a couple of housekeeping items. I will do my best to leave time for some questions at the end of the webinar, so feel free to type your questions into the chat box. But I likely will not have a chance to look through those until we get to the very end of the webinar. I also sent a message through the chat box that we will be recording the webinar and posting it on our website and YouTube pages. So if you have colleagues or friends or family that were not able to join today, please feel free to share the recording with them once we get it posted. So just as a quick little bit of background information, in case you're not super familiar with the CLRC, the Cancer Legal Resource Center's mission is to provide free information and resources on cancer-related legal issues to cancer patients, survivors, caregivers, healthcare professionals, employers, and others coping with cancer. We are a program of the Disability Rights Legal Center. We're based in Los Angeles, California, but our program is national in scope. And we generally follow an education model as opposed to litigation. So we provide information and resources, but generally do not provide legal advice or represent clients directly. We maintain a library of fact sheets and publications on a variety of cancer-related legal issues on our website, including a resource called our Patient Legal Handbook. The handbook provides a brief overview of many of the most common issues and questions that people living with cancer and their families have. We have a new version that we're hoping to release probably early to mid-May. So please stay tuned and check our website out for updates. If you are a healthcare professional that's interested in receiving copies of the handbook for free, or if you're a patient or caregiver that's interested in receiving copies, please feel free to reach out to us. We can add you to our wait list. We'll also have a pre-order page on our website, hopefully within the next couple of weeks. We have a number of webinars coming up over the course of the rest of the year. The next one is in May, and it covers financial toxicity. We're also doing a webinar on housing rights, medical marijuana, health insurance, etc. So if you're interested in registering for any of the other webinars, please feel free to check out our website at cancerlegalresourcecenter.org. So like I said, I will try to leave some time for questions at the end of this webinar, but if I'm not able to get to your questions, or if you have questions that I don't know the answer to, please feel free to follow up with us. We provide assistance in the form of information and resources through our national telephone assistance line, as well as our website. So the best way to get in touch with us is through our online intake form at clrcintake.org. If you're not able to access the form for some reason, you can certainly leave us a voicemail at 866-THE-CLRC, and we can give you a call back to complete the intake over the phone. And all the information we provide is free, but as I mentioned, we do not provide legal advice or direct representation. So today we're going to be talking about a number of issues that are certainly relevant to everyone literally everyone, regardless of whether or not you currently have or will ever have cancer. But before we dive in, I just want to give you a quick overview of the topics we're going to cover. This webinar is especially timely because Monday was Advance, I believe it's, National Healthcare Decisions Day. And then if you've been following the news at all, Barbara Bush recently passed away a couple of days after announcing that she was only going to be seeking comfort care. So, I'll tie some things back to her situation throughout the webinar today. So first, we're going to talk about palliative care, what it is and what it isn't, important considerations around palliative care. And then we'll go over some basic information about hospice care and how those two things are different. Next, we'll talk about some of the options that a person has with respect to treatment or lack thereof at the end of his or her life. And then we'll finally talk about some ways to ensure that your hopes, wishes, priorities will be documented in a way to ensure that they will actually be honored at the end of your life. And just as a reminder, I am an attorney. I am not a medical professional. So I will not be discussing the pros and cons of any specific types of medical treatment today. Any questions about specific pain management options, diet, or other treatments should be directed to your healthcare team or some other specialist. Okay, so a little background information. Life expectancy in the US has increased to about 78 years. And while we're living longer, many of us are going to live with serious illness if we aren't already. So how do we help people live well with serious illness? When the life expectancy was shorter and when we had far fewer medical interventions and cures for certain types of conditions or diseases, we didn't really have to think about quality of life or how to manage some of these situations long term. People didn't have to think about this when we got sick quickly and died quickly. And, unfortunately, despite the fact that literally every single person on the planet will die at some point in the future, that's just an inescapable truth. Talking about our own mortality or the mortality of our loved ones or our patients or clients can be extremely challenging. Comfort levels around this topic really vary greatly, and so that can lead to a lot of unfortunate issues down the road if these conversations are not initiated. So that being said, what is palliative care? There have been a lot of discussions in the news lately, specifically, with respect to Barbara Bush, but there have been a lot of conversations about what is palliative care, who is it for, how does this affect people? So one definition of palliative care is medical care focused on improving quality of life for people with serious illness. So as you see from that definition, I did not say terminal illness. It says nothing about end of life. Palliative care plays an important role throughout a serious illness or chronic illness. A lot of people seem to be misinformed or have, for whatever reason, associate palliative care with end-of-life care exclusively. And that's just really not the reality. It is not hospice care. It's not only for people with terminal illness. Barbara Bush's statement about only seeking comfort care and not seeking medical care isn't really 100% accurate, because comfort care is still medical treatment. It's just not curative. So palliative care means making someone comfortable by treating their symptoms from an illness without curing the underlying disease. There might still be curative treatments going on, but palliative care is addressing some of those side effects and quality of life. So the common misconception when we think about treating a disease or chronic condition such as cancer, we often think that we're forced into making a decision between quality of life and quantity of life. So, you might think, well, I want to live as long as possible. So does that mean that you need to take every single available treatment for your disease, go through heroic measures, even if it makes you miserable? Curative treatment for cancer might include things like radiation, chemo, surgery, etc. And then on the other side of things, maybe it's more important to you to have some sort of quality of life, even if that means sacrificing some of the length of your life to achieve that quality. It's really not one or the other. That's the main point that I'm trying to make here, is that palliative care can help you achieve both of these things, quality and quantity of life, at the same time. There are studies that have been done that show that people who receive palliative care at the same time as curative treatment um, often have better quality of life, better mood, less pain. They're less likely to get invasive care at the end of their life, and they often live just as long, if not longer. Sometimes some people that receive palliative care are able to hold on longer because their symptoms are managed appropriately. Several studies also show that people who receive palliative care and or hospice services have better outcomes for their family. It can reduce the costs of care. As I said, less intensive care at the end of their life, maybe fewer hospitalizations. And, in some studies, like I said, some patients live longer with palliative care. Nothing has ever been shown that palliative care shortens life. So there are really no known downsides to palliative care. And palliative and curative care can and should be given at the same time. So what exactly does palliative care entail? I think a lot of us immediately think of pain and symptom management. So while palliative care does often encompass pain management, that's not the only thing that it includes. Palliative care can make it easier on loved ones because there is emotional and spiritual support, potentially family and caregiver support. Palliative care might be physical therapy, mental health services. Support groups are one form of palliative care because they provide, emotional support. Palliative care, obviously, like I said, can be given at any time during a patient's illness. So, another form of palliative care might be consulting with a nutritionist to make sure that the patient can keep his or her weight up, or to address, to use diet to address other side effects, to figure out what types of foods might taste okay. If the person is having issues with their food tasting differently after, chemotherapy. Depending on the other side effects that someone is going through or the effects of their treatment, maybe speech therapy is something that they might have to, approach. And then, like I said, pain management is certainly a big part of the palliative care sort of coordination. So who provides palliative care? It's often provided by an interdisciplinary team, sometimes known as a supportive care medicine department, the integrative medicine department. They go under a few different names. So these teams, these interdisciplinary teams, can include support groups. At some hospitals, patients are assigned a social worker who then might be in contact with your psychologist, who are all in contact with your oncologist and your pain management specialist. They might also coordinate with your primary care doctor, nurses, nutritionists, chaplains. And this way, because they're all sort of connected and coordinating, they can provide care and share an understanding about what the patient and his or her family are actually going through, which might help inform some treatment decisions. They're depending on what's going on at home, what type of support the patient has, et cetera, that might, help dictate what the schedule should be, when the next appointment should be, how aggressively someone wants to treat something, or whether they want to try to, join a clinical trial or something like that. But it really helps look at the entire patient and not just at, whether or not their disease is progressing or not. So there's a lot more to it than pain management. Like I said, all of this takes place in coordination with your active treatment. I met a woman recently whose brother was repeatedly admitted to the hospital for severe pain, not knowing that they could have been seeing a pain management specialist to improve his quality of life. So, the goal of having all of these different healthcare providers working together is obviously to provide coordinated care, but also to help, use that care in a way that improves the patient's quality of life. So, unfortunately, sometimes doctors will tell patients that they are not ready for palliative care. You do not have to be dying or have a terminal diagnosis in order to be eligible for palliative care. It is very important to ask for the referral if it is not being offered to you. And if your doctor or hospital or insurance network does not have palliative care doctors to refer you to that are either close by or within your network, you might want to consider seeking additional treatment elsewhere or asking for an out-of-network referral if you have to. Most insurance plans, including Medicare and Medicaid, cover all or part of palliative care treatment, just as they would cover other hospital or medical services. For example, if a patient is depressed and needs to see a mental health professional and potentially be prescribed antidepressants, that would generally be covered by any health insurance plan. Same with pain medicine, consultations with a nutritionist, etc. The main thing to keep in mind with palliative care is that you can and probably should be referred to a palliative care team as soon as you're diagnosed, and or if you have symptoms or stress that are difficult to manage. If you're dealing with your treatment and diagnosis without any real, stress issues or pain issues or nutrition issues, etc., you still might want to check in with a palliative care doctor or team annually, just so, they're sort of keeping track of how things are going for you, and that they're available should things take a turn where, you're experiencing more symptoms. Now, you might need, so if you are the patient, you really might need to advocate for yourself, because a lot of doctors, and I'll go into this in a little bit in a couple of slides, but a lot of doctors are just, this is not what they're trained to do, and they might not be thinking about all of the side effects. If they're trained to, treat cancer, that might be what their focus is on. They might have blinders on to the rest of the issues that could potentially arise. If it's your loved one that is sick and potentially needs this type of supportive care, you might have to be the one that's advocating. And for the healthcare professionals that are joining us on today's webinar, please try to be good advocates for your patients. Not all of them are aware that palliative care is something that is even an option for them. So if you can play a role in, informing them about what they might be entitled to and what might be able to improve their quality of life, I'm sure that they would be eternally grateful. So we just discussed palliative care and the fact that you do not have to have a terminal illness to receive palliative care. Palliative care can be received at any time. If you, go into remission, you're cancer-free for, you might not need palliative care during that time. So palliative care can be started, it can be stopped, regardless of, your prognosis, your long-term prognosis. Hospice care, on the other hand, does require a 6-month terminal prognosis. So palliative care is a very important part of hospice care, but in order to be eligible for hospice care, you generally have to have a 6-month prognosis. So 35% of people in the United States who are referred to hospice spend 7 days or less. So that means that potentially for 5 3/4 months, while the person was potentially in pain or suffering, they might not have sought out hospice care. People are often referred very late to hospice. Even Barbara Bush, like I mentioned, she announced 2 days before her death that she was only seeking comfort care. Obviously we might not know the full details about what types of treatments she was receiving, but often people are referred to hospice care very late in the game. A lot of people say that they wish that they had been referred sooner. And 15% of people who are referred to hospice are actually discharged because they get a little better. They get better and maybe their prognosis changes. So hospice care is one way to get palliative care at home, which can be really helpful with achieving a good quality of life. You don't have to be homebound. You don't have to be hospital bound. Depending on your situation and how your disease is manifesting itself and what types of side effects you have. I mean, you can be on hospice care and still go on vacation and simply coordinate with a hospice service wherever you're going, making sure that you'll have access to someone there if necessary. But I think a lot of us imagine hospice care as something that happens only at the very, very, very end when you are in a bed in a hospital or facility somewhere, literally on your deathbed. And it doesn't have to be that way. Again, hospice care is provided through an interdisciplinary team, doctor, a nurse, potentially home health aide, social worker, chaplain. Often care is provided by loved ones, and it treats the whole family as the patient. Hospice care includes bereavement support for loved ones. So, it doesn't just end as soon as the patient passes on, which can be very helpful for the caregivers and family members. So I already alluded to this a bit. Where can you receive hospice care? Most people don't want to die in a hospital or in the ICU, but a third of Americans do. A third of Americans do die in a hospital. Most people would prefer to die at home. And, sometimes it's sudden, an emergency or a crisis happens and there's not really much that you can do. But if it's foreseeable that at some point in the future you might be looking into hospice care, it's a good idea to talk about your wishes. Would you prefer to have this provided at home? Most hospice programs offer home hospice services. The main caregiver is usually a family member or friend who's responsible for around-the-clock supervision of the patient. And this person is with the patient most of the time and is trained to provide much of the hands-on care. And then you can receive additional assistance through home health aides, etc. There's usually hospice staff on call 24 hours a day, 7 days a week. But if home isn't an option for whatever reason, freestanding hospice centers exist. You can get hospice care if you're in the hospital already, and if you live at a nursing home or long-term care facility. Hospice is covered by Medicare, most Medicaid programs, and most private insurance. The following services might be available to you with limited cost sharing depending on your healthcare coverage. So it might be routine care, inpatient care, continuous care, respite care for your caregivers, medications, equipment and supplies, 24-hour on-call access, and then, as I mentioned previously, grief support for the family. Home hospice care usually costs less than if you're in a hospital because obviously your caregiver might not be getting paid anything to take care of you. Generally, there are some other hospice providers that might be available if you don't have insurance or if you can't afford hospice. Some programs charge patients according to their ability to pay. 93% of hospice care is provided at the routine home care level. So that's where, you know, the family caregiver is providing most of the care. They have someone that comes, you know, every once in a while to check in or to provide, you know, maybe a higher level of assistance that maybe the home or the caregiver might not be able to give. But then there's also continuous home care. If the person's in a medical crisis, they might have to have a nurse or other, you know, health aide present if the family member can't provide a certain level of assistance. There's also inpatient care that happens in a facility if, you know, the person's symptoms cannot be managed at home at all. And then there's also inpatient respite care. So if a caregiver really needs a break from taking care of their loved one, you know, Medicare will cover some inpatient respite care, I think up to 5 days in a row. So there are obviously a lot of challenges in seeking and receiving hospice or palliative care. That's part of why we are hosting this webinar today, to try to break through some of those misconceptions. The reality is that, and I love doctors, I love healthcare professionals, I in no way am trying to demean doctors when I say this, but the reality is that doctors were trained to help make people better. They were trained to cure ailments for the most part. So many of them are unfortunately just not adequately trained or equipped to share bad prognoses with their patients for fear of potentially looking incompetent. They don't want to look or feel like a failure. And also because they might not want to upset or disappoint their patients. It might seem sort of silly because you think, oh, well, a doctor, this is their job. This is what they're supposed to do. But they're people, you know, they're humans too, and they don't always know how to appropriately handle difficult situations. Nobody likes giving bad news. You know, it's that can be really tough even for someone who's trained very well, especially if you have a relationship with the patient, you've been treating them for a long time. So, you know, I do want to cut them a little bit of slack because that's a very challenging part of their job. But, you know, and sometimes the prognosis is also difficult to estimate. So, you know, if you're thinking about, okay, well, I would like to get referred to hospice care as soon as it makes sense to do that, it might be hard for a doctor to say, yes, you only have 6 months or less. But that's also an argument for getting palliative care as soon as possible and potentially as soon as you are diagnosed. That would potentially, you know, make things a little bit easier if your doctor is not sure or not able to, you know, yet refer you to hospice care. You know, doctors are also often reluctant to refer patients to hospice or palliative care. I know an oncology nurse practitioner who just told me 2 days ago that she referred a patient for palliative care, and the patient went to see her primary care doctor, and the primary care doctor said, "You're not ready for palliative care." Clearly, that primary care doctor does not understand what palliative care is. There is a difference between palliative care and hospice. And, you know, sometimes it is up to the patient or the patient's advocate to make that clear to the doctors if they're refusing to make those referrals. You know, the other thing to keep in mind too is that doctors will often hold out an unrealistic hope about a cure or about new treatments because they think that's what the patients want to hear. You know, they might offer additional treatment options just so that the patient and family don't feel hopeless, even if the treatment might not actually be, you know, super helpful in extending life or might really negatively impact quality of life. Sometimes it's sort of like throwing in everything but the kitchen sink, trying to find some sort of cure or slowing of a disease without really taking into account how that's going to affect the patient and their family. couple other challenges in seeking or receiving hospice or palliative care, stigma. Patients themselves often have limited information about palliative or hospice care, and they also might not know the difference. Again, that's part of why we're here today. They might also feel like requesting palliative or hospice care might imply to their loved ones that they're giving up or that they aren't strong enough to handle things on their own. There is still a lot of stigma just out in the world attached to seeking mental health services. So some patients might be less likely to ask for that type of support. And these days, there is also a lot of stigma around pain medicine and addiction, and many patients might not be able to communicate effectively how severe their pain is, or doctors might not listen. This is supposed to be improved by routine pain evaluations, which, generally take place every time you see a doctor. But, that's not always the most effective way to evaluate someone's pain. Additionally, if the patient himself or herself has not thought about his or her own values and hopes, and or has not communicated them to the healthcare team or to their loved ones, it can be really difficult for the healthcare team to know how to be most helpful. There's a lot of deference to what the healthcare team suggests or talks about, and potentially not as much deference is given to the patient to come up with their own goals and hopes. So a couple of important questions. Realistically, the questions on this slide: what do I hope for? What matters the most to me? How might I achieve that? Those are questions that your healthcare team should be asking you if you're the patient. But for the reasons I mentioned on the previous slide, some doctors are ill-equipped to initiate these conversations. You can help the doctors and nurses by explaining your values and how you hope they can help you. For the patients and survivors watching today, the hardest part might be honestly answering some of these questions to yourself. Assuming you can't live forever, what do you hope for? You can hope for a cure, certainly, but there might be other things that you hope for as well. There might be really specific goals or hopes. Of course you're going to hope for a cure, but if you can't get that, is your goal to take your grandson to Disneyland when he comes to visit 3 months from now? Is your goal to be able to attend, your nephew's wedding that's, out of state? Is your goal maybe something even more simple, to be able to spend time in your garden at home? If you have those types of specific goals or hopes, things that you would like to be able to do, it certainly it can't hurt to share that with your healthcare team, because maybe they won't be able to find a cure within the next 3 months, but maybe they can figure out a way to make you comfortable enough to be able to take your grandson to Disneyland. And without communicating those types of hopes or goals to your healthcare team, they have no idea that that's even something that they should be thinking about. And you might not be able to get those accomplished without their assistance. So it's definitely a good idea to have these types of conversations, both with your loved ones, but also certainly with your healthcare team, because that can really help evaluate what types of supportive services or what types of curative treatments you want to pursue or not pursue. One last tip here, your provider or your health insurance company can likely refer you to hospice or other home health providers, but it's always a good idea to do some research on your own about these services, the same way you might have researched your primary care doctor or your oncologist, because it's really just as important to have people that you really trust around you at the end of your life. There are thousands of hospice providers nationwide, and it's always a good idea to check reviews or other crowdsourced information to ensure that you're comfortable with the company or the facility that you choose, especially if you follow a certain religion or faith. Some hospices are faith-based. You might want to select one that aligns with your values. All right, so moving on here. patients' rights with regarding end-of-life care. Regardless of whether you or your patient has been referred to hospice or palliative care early enough, we all reach the end of our lives at some point. So one right that someone has at the end of their life is to refuse food or water. This is sometimes referred to as voluntary stopping of eating and drinking, VSED. It's a good idea to record this wish if this is something that you have in your Advance Health Care Directive, which we'll talk about in a minute. Appropriate supportive care should be arranged for in advance, but generally speaking, everyone has this right. VSED has come up in the news recently because there have been some situations where patients with dementia have continued to be hand-fed, and some states actually prohibit the withdrawal of oral assisted feeding. Additionally, some nursing homes and other facilities might have policies that require the provision of food and water. Sometimes this is just to protect themselves against elder abuse accusations. So if you or your loved one is moving into a facility or living in a nursing home or other facility and contemplating VSED, make sure that you do your research because you could possibly either get evicted or they might just refuse to allow you that option. So patients also have the right to refuse medical treatment. This has been challenging for some of the people that have contacted our hotline, especially those who are family members of the patient who is refusing treatment. So if we keep in mind that the ultimate goal is not only maintaining someone's quality of life, but also trying to maintain their patient autonomy for as long as possible, we have to remember that, the family, the healthcare providers, et cetera, do not necessarily have to agree with the course of treatment or lack thereof that the patient decides to take, as long as that person is mentally competent and, able to make decisions for herself. There's often so much pressure to try everything, and, there are significant healthcare costs towards the end of someone's life as everyone is, piling on different types of treatments to try to, stave off what is potentially the inevitable. So, if these are happening at the expense of someone's quality of life, that patient certainly has the right to refuse to continue medical treatment. Not all patients experience excruciating pain at the end of their life, but recognizing pain and treating it effectively is essential. The hospice care team will evaluate a patient's pain on every visit, but pain management has become sort of a hot button issue today because we've heard a lot about the opioid crisis in this country, and there are sometimes concerns that we hear from family members that they are worried that their loved one with cancer will become addicted to pain medicine. However, the standard of care for pain management of terminal cancer patients is that they have their pain adequately managed. There are not really upper limits as to how much pain medication is appropriate for someone who's dying, and there's no time for someone to develop an addiction. Using the most effective tool for pain relief should be the primary concern. If someone is in a lot of pain and they are at the end of their life, you do not have to worry about whether or not they are going to become addicted to their medicine. There have also been a lot of limits on opioid prescribing, and those limits are really not supposed to apply to people who are in hospice or have cancer pain. But, in the real world, we know that, CVS pharmacy, for example, limits opioid prescriptions for acute pain to 7 days. So if this is, you've just had surgery and you need painkillers to address the pain from that surgery, you might have to go back to your doctor every 7 days to get a new prescription. Some hospices have had issues with drug shortages due to decreased production as a response to the opioid crisis. Like I said, pharmacies have a number of their own policies. Patients have been denied prescriptions because the prescribing doctor had reached a monthly limit. Sometimes hospice or palliative care patients run into roadblocks with their health plans because insurance companies are increasingly requiring prior authorizations for opioid medications. So, just keep in mind too that there are potentially other types of pain management options, like physical therapy, acupuncture, massage therapy, psychological approaches like hypnosis, guided imagery, meditation, medical cannabis, for example. But some of those alternative therapies, like medical marijuana, for example, might not be covered by insurance. So that's just one thing to keep in mind. Patients also have the right to something called palliative sedation, also referred to as terminal sedation, sedation to unconsciousness, or total sedation. It's not the same thing as aid in dying. So palliative sedation is something that is reserved for extreme situations, and it essentially lowers the awareness towards, it makes it possible for someone who's really struggling to deal with their pain or their other symptoms. It offers them the opportunity to be unconscious during that time, to while they're struggling to manage their symptoms. It doesn't have to be permanent. In some situations, in limited situations, it can be appropriate to sort of increase their consciousness again. But for the most part, people who choose palliative sedation remain unconscious until they pass on. Some states have also given patients and their doctors the right to medical aid in dying. The states that do have a right to aid in dying generally have specific procedures for making and granting the request. You usually have to have multiple evaluations, including by a psychiatrist. You might have to request the medication multiple times with a lengthy waiting period in between. And the patient has to be an adult, generally has to have 6 months or less to live, be able to make informed healthcare decisions, and be able to take the medication themselves. It's optional for doctors and also for the patients, obviously. And most patients who request the medication don't even end up taking it. It just provides them with some peace of mind. So these are the states that it's currently permitted in. Hawaii just passed its medical aid in dying bill just, I think, at the beginning of the month, and it will go into effect January 1st, 2019. So really quickly, I'm going to go through some advanced planning tools. I've covered these tools in other webinars, and we also have a number of educational materials on our website that talk about these. So I'm going to go through kind of quickly, but I want to make sure that, now that we've talked about your options with respect to palliative care, hospice care, the types of treatments or lack thereof that you might want to seek at the end of your life, I want to make sure that you're aware of the documents that you can create where you can hopefully try to ensure that those wishes will be upheld. One thing to keep in mind is that estate planning laws and advanced planning laws do vary a bit from state to state. I'm not going to be talking about wills, trusts, or powers of attorney for finances, but I do recommend that you check out some of our other materials on our website. So, tools for planning ahead for healthcare. We're going to talk a little bit about Advance Health Care Directives, powers of attorney, living will, DNR, and POLST or MOLST. So first, the Patient Self-Determination Act was enacted in 1990, and the purpose of this law was to inform patients about their rights regarding decisions about their own medical care and ensure that their healthcare provider communicates those rights to them. Patients have to be given written notice upon admission to the hospital or the healthcare facility of their decision-making rights, and policies regarding advanced healthcare directives in their state and in the institution to which they've been admitted. It requires hospitals, nursing homes, hospice providers, healthcare institutions, etc., to provide information about Advance Health Care Directives to adult patients upon admission. So the facilities have to ask about whether the patient already has an advance directive, and they also have to educate their staff about advance directives. Patient rights also include the right to facilitate healthcare decisions, the right to accept or refuse medical treatment, as I previously mentioned, and the right to make advance healthcare directives. Okay, so what is an advance healthcare directive? It is written instructions that state a person's wishes about the medical care and treatment they want to receive if they are unable to make medical decisions for themselves. Advance healthcare directives are intended to avoid unwanted care, reduce suffering, and ensure that a person's wishes are honored at the end of their life. For example, you can state your desires regarding life-sustaining or life-prolonging medical treatment or pain relief. And unfortunately, I just read this statistic, approximately two-thirds of Americans lack advance directives. And I'll talk in a second about why that is very challenging. So generally, advance directives have multiple component parts. Those will vary from state to state. We're here in California, so as an example, California has 4 parts to an advance healthcare directive, including power of attorney for healthcare, instructions for healthcare, organ donation, primary physician identification. But I do want to flag that, many hospitals have their own advanced healthcare directive forms that hopefully have been drafted in such a way that they comply with the laws in the state where the facility is located. But if you go to a hospital that doesn't have its own form, or if you are not really sure about, what would I put in an advanced healthcare directive? How would I start one? There are free forms available on this website, www.caringinfo.org. Every single state has a free form available on that website. You can print them out for free, fill them out. There are detailed instructions, and so this is a legal document that you absolutely do not need a lawyer for. You should not have to pay anyone to complete an advance healthcare directive. It's possible that you might have to, have it notarized, but I'll talk about that in a minute. So I definitely recommend checking out caringinfo.org for free advanced healthcare directive forms. So part 1, power of attorney for healthcare, also known as your agent, your proxy, your surrogate decision maker. There are a lot of different titles for this person. So the power of attorney for healthcare names someone, could be a relative, friend, someone else you trust, to make medical decisions for you when you are not able to do so. A power of attorney deals with all medical decisions unless you decide to limit it. And you can also give specific instructions about treatments you want or don't want, or other issues that concern you. The person usually has to be someone that's over 18, can't be your doctor or someone that works in the hospital or clinic where you get treatment. So there are certain aspects or qualities that you might want to look for when you're thinking about who you would want to name as your agent or your surrogate decision maker. So you're probably going to want to name someone who's trustworthy, someone who shares your values, and someone with whom you've actually talked about what your end of life wishes are. I watch the TV show Grey's Anatomy. I have watched it from its inception, and I distinctly remember an episode when one of the characters is surprised to find out that she has been named someone else's surrogate decision maker. It should never be a surprise. So if you are thinking about creating an advanced healthcare directive and trying to think of who you would name as your agent, please make sure you have the conversation with the person before you actually complete your form, because it would be a terrible tragedy if you named someone who then refused to serve and therefore your wishes were not upheld Or even if you did name someone who expected to be named, you want to make sure that you've actually talked about what your wishes are, because they might assume that your wishes are something other than they actually are. So that is imperative to have that conversation. Here's why it's important to name a surrogate decision maker. What if you have no family available? What if you don't have children and you're not married? Who's going to make the decision for you? States have laws that set defaults for surrogate decision makers. The laws usually have a hierarchy of authorized family decision makers who can make medical treatment decisions on someone's behalf. If there's a spouse, usually that is the default. But, if you don't have a spouse, if people are unavailable, what if the default person doesn't want to make decisions? Or what if you really don't have a good relationship with the person who would end up being the default? What if you have very well-intentioned family members who disagree with each other, and no clear guidance on what your wishes might have been or might be? What if your family doesn't share your values? What if you were raised in a certain religion or faith and you've left that faith, or you've found a faith that your family doesn't subscribe to? There are a number of ways that can potentially negatively impact the patient. So it's really important to think about who you would want to name, have that conversation, make sure that they understand what your wishes and goals would be, so that these decisions, these potentially life and death questions, will not be in the hands of someone that you don't trust or don't know. So part 2 usually of an Advance Health Care Directive is called the Instructions for Healthcare or Living Will. A living will is not the same thing as a will where you decide who's going to get your property after you pass. Generally, the living will or instructions for healthcare is where you can be as specific as you want or as vague as you want about the types of treatments that you would like to receive, or not, at the end of your life. So, for example, maybe you don't ever want to be on a ventilator. That's something that you could put in your instructions. Maybe you do want a feeding tube, but only for a limited amount of time. You can put that in there as well. So like I said, you can be as specific as you'd like. There can be other components of Advance Health Care Directives. Like I said, they vary by state. Some states offer organ donation, and that's sort of like one more way to potentially offer your organs in addition to maybe on your driver's license. Certainly some types of cancer, you might not be able to donate organs. That's just an aside. Some Advanced Healthcare Directives also offer an opportunity for you to name who your primary physician is. And then there's always some sort of signing requirement. So some states allow you the option to just have 2 witnesses. Some states require that the form be notarized, and some states give you an option, so witnesses or notary. A lot of hospitals have notaries on staff. So if you are completing an Advanced Healthcare Directive while you're in a facility, usually you can have it notarized right there. And it's not too big of a hassle. So you can also have a do not resuscitate order, which would notify caregivers that you do not want to be resuscitated in the event that your heart stops beating or you stop breathing. You can include this in your Advanced Healthcare Directive, and you can also request an out-of-hospital DNR order if you do not wish to be resuscitated if you have problems at home or anywhere outside of a medical facility. The issue there is that, if somebody doesn't know that you have that form, maybe you have a home health aide that's, you're in distress, they call 911, they don't know where the DNR is or they've never seen it, that can get a little bit challenging to make sure that everyone's aware. But it is a formal legal document. Generally, you have to have it signed by a doctor. The patient has the right to revoke it at any time. So another tool for planning ahead for your healthcare is something called a physician order for life-sustaining treatment, also called a medical order for life-sustaining treatment in some states. It's similar to an advance directive in that it might address pain management, resuscitation, or feeding, but the POLST is completed with the approval of both the patient and the physician, and it guides emergency medical treatment. It has the force of a physician's medical order, and it actually remains with the patient wherever they receive care because it becomes part of the medical record. It's usually printed on a bright pink piece of paper, so I did not select this color that's on the slide. It's generally bright pink. That way it's easy to see on the patient's chart. And the other issue, if it's there available at the hospital or with the medical record, advanced healthcare directives might get lost. The family might not know where they are. Some states have registries where you can register that you have an advanced healthcare directive, but I think many of those registries you can't even access. The form, the advanced healthcare directive form, the doctor can just check and see whether there is one theoretically that was created somewhere. So, the benefit of having a POLST might be that it's going to be more easily accessible and possibly more likely to be enforced, since it would be right there with you, and you never know where your advanced healthcare directive might end up. That's another thing to keep in mind too about advanced directives. Once you have that conversation with the person you're naming as your agent, you might name someone to be an alternative agent if the first person isn't available. I would make sure both of those people have copies of your form, and then also have it somewhere else safe in your house. Make sure you share it with your doctor. But there's a little bit of a difference between advanced directives and POLST. So I wanted to make sure that I could leave a couple of minutes for questions. These are a couple of resources. Like I said, caringinfo.org is a really fantastic resource for accessing advanced healthcare directive forms. If you have questions about aid in dying or other end-of-life issues, Compassion and Choices is a great resource. And I just want to remind everyone, it's not the years in your life, it's the life in your years. This quote is often misattributed to Abraham Lincoln, but I really like it nonetheless. Don't be afraid to discuss your goals and your values with your loved ones and your healthcare team. You are your own best advocate for your quality of life, and there are legal tools and documents to help ensure that your values are honored even when you're no longer able to speak for yourself. So with that, I'm happy to open it up for questions if anyone has any.